Thank you all for coming. So we'll get started with this one. I'm on the Speaker Bureau for Actelion and Bayer. So CTEPH is a complication of PE. I think that's important to recognize. So most of the patients who are diagnosed with CTEPH have had PE at one point in time, even though a lot of them, might not know about it. So the estimated incidence of CTEPH after PE is about 0.4 to 9%, depending on what study you look at. Now, the most widely cited, or one of the best studies of long-term follow-up of PE patients, which with complete follow-up, is the study by Pengo et al., which looked at about 223 patients with PE, and symptomatic CTEPH was about 1% at 6 months, 3.1% at 12 months, and 3.8% at 24 months. And as you can see here, after that time, there is no further incidence, and it looks like that remains stable. However, in patients with the recurrent PE, the incidence can be as high as 33%. In another study, again, coming out of Europe, out of the 146 patients with PE, about 4.8% of patients developed CTEPH in a median follow-up of about 26 months. And again, like I said earlier, 25 to 30% of patients with CTEPH do not have a history. So a lot of them might have had asymptomatic PEs and then go on to develop CTEPH. So the incidence of CTEPH, like I discussed earlier, is really not very well known because a lot of these cases go undiagnosed. So because if you look at, this is just a hypothetical situation where if you look at there are 600,000 PEs, this is just in the US. So it gives you, even if you take a population incidence of 0.5%, which is the lowest, then there should be at least 3,400 CTEPH cases. And if you look at an additional 30% of CTEPH cases per year in patients without PE, overall you're looking close to about 4,500 CTEPH cases. And if you look at the number of surgeries being done in the US for CTEPH, it's only about 300 to 400. And if you add another, maybe 300, 400 patients who go have medical therapy, it's still about less than 20% of patients who are being currently identified. So there's a huge gap here in terms of how many might have, developed CTEPH and how many we are diagnosing every year. So what are the risk factors which lead to development of CTEPH? Again, previous PE, again, odds ratios up to a 19, younger age, because it gives them longer time to develop vascular remodeling, larger perfusion defects, and again, idiopathic pulmonary embolism, because these patients who have idiopathic PE are at higher risk of developing subsequent PEs. So they are that's why they are at higher risk of developing CTEPH. Again, PA systolic pressure of greater than 50 on echo within the first 6 months of developing a PE, recurrent PE and persistent PH after 6 months on echo. So all these are PE-related risk factors. So when you're looking at following up a patient with PE for CTEPH, this could be a subgroup of patients whom you can follow closely to see if they developed CTEPH. Now, looking at thrombotic risk factors kind of makes sense that patients who have a thrombophilia could be at high risk for CTEPH, but it's not very uniform. Patients who have lupus anticoagulant and antiphospholipid antibody have been associated with CTEPH. However, if you look down, the deficiency of antithrombin, protein C and protein S, and the presence of the prothrombin mutation and hyperhomocystinemia are not associated with CTEPH. And in a study of about 122 patients, increased von Willebrand factor and factor VIII were more common in CTEPH compared to patients who were both PH and with controls. So what are the other patient risk factors which are associated with the development of CTEPH? So presence of VP shunts and infected pacemakers, splenectomy, non-O blood groups, thyroid replacement therapy, and history of malignancy. Now, a lot of these are associated either with increased risk of infection, like with VP shunts and infected pacemakers, or decreased clearance of microthrombi, which happen in splenectomy, and history of malignancy, which is really a prothrombotic condition. So when we look at all the risk factors and look at the role in pathogenesis, so patients get a PE, and then there is an incomplete resolution and organization of thrombus, and this is likely due to all these other factors that we talked about earlier. You have an infection, which is a prothrombotic state, and you have inflammation, which again doesn't help with thrombus resolution, and certain genetic factors, which again play a role in incomplete resolution of thrombus, and that leads to fibrosis and then stenosis and occlusions, and subsequent vascular remodeling of resistance vessels. So this is just histology from a lung tissue taken during PEA, and as you can see here, these are completely obliterated vessels. And when you look at the resistance vessels here, this is all collagen, which shows that there is a lot of collagen deposition in the media of these vessels, and this is staining for myofibroblasts, suggesting that once fibrosis sets in, the fibroblasts come in, and then they actually transform into myofibroblasts and lead to smooth muscle hypertrophy in the media. So again, going over some of the things that we discussed, it's really a dual pulmonary vascular disorder where you have thrombosis and there is small vessel pulmonary disease or pulmonary arteriopathy that you actually see in pulmonary arterial hypertension. So the vascular lesions are a mixture of both thrombosis and arteriopathy, and the vascular lesions really comprise of muscularization, concentric, intimal fibroelastosis, and medial hypertrophy. All these are fairly characteristic of patients with PAH. So again, if you look at what happens in the pulmonary vasculature, so the arteriopathy predominates in areas with patent feeding vessels, and distal to chronic stenosis, there is paucity of vessels. So, and there is also a thought that a lot of these risk factors which are associated with CTEPH actually lead to small vessel disease, such as VP shunts, splenectomy, all these things lead to more of small vessel disease. And the PVR, or pulmonary vascular resistance, in these patients may actually reflect small vessel disease and definitely impacts prognosis. And there are a couple of studies which have looked at nitric oxide challenge in these patients, and again, improvement with the nitric oxide challenge actually may suggest small vessel disease in this patient. And again, the reason to intervene early in these patients is to sort of prevent the progressive cascade and halt progression of small vessel disease. So in conclusion, CTEPH is actually more common than originally believed, but still very under-recognized. And history of PE may be missing in a lot of individuals, and that should not dissuade us from thinking about CTEPH in these patients. And the history of risk factors that I mentioned, whether it's VP shunt, splenectomy, pacemaker, dialysis catheters, all these things should raise a suspicion of CTEPH. And understanding the varying degrees of small vessel diseases, which is present, is key to prognosis and decision making. Thank you very much.